Hello, it's Dr. Janice Huntingford again, and this particular segment is on acute post-operative rehabilitation, because there are some very specific things that we do in the immediate post-operative period that we need to discuss that are a little bit different from some of the things we have previously discussed. So when we talk about post-surgical rehabilitation, we need to think about a few things. And one thing that we know is that physical therapy for humans really focuses a lot on post-surgical patients. And it's very, very common for post-surgical patients to have physical therapy. And it is very important to recognize as a rehabilitation practitioner that the healing times of tissues, which we've gone over in our wound healing section, is something we need to think about when we are designing post-surgical rehabilitation protocols. Now, the anterior cruciate ligament surgery is very common in both humans and in dogs, and post-operative rehabilitation has been studied very, very thoroughly for this condition in people, more so than any other orthopedic surgery. And oftentimes in humans, the anterior cruciate repair rehabilitation is used as a model for all the other post-operative rehabs. And so we're going to do that for dogs as well. So this is our little chart that shows us the phases of wound healing. And we have to remember that there are really three phases. There's the inflammatory phase, which for the most part lasts from surgery up to 72 hours. And then we have the reparative phase and the maturation phase. And those timelines will be a little bit different depending upon which tissue you're dealing with. But as a rehab practitioner, we have to have some idea of what's going on with each tissue so that when we are designing our post-operative protocols, we do not disrupt the surgeon's work, because they get very upset about that. So let's think about, particularly if we're thinking about knee surgery and we're thinking about dogs who have had, for example, TPLOs. Let's think about bone healing at first. And we have gone over this in the wound healing strategy section, but I did want to emphasize this again so that we think about it. We need to remember that bones are made up of type 1 collagen and a ground substance with the mineral crystals in there, the hydroxyapatite crystals. And bones are a balance of the collagen and the mineral, and that makes them viscoelastic so that they are able to bend. That makes them responsive to stresses. But the big thing when we're thinking about rehabilitation is we need to think about Wolff's Law. And Wolff's Law says that in a healthy individual, a bone is going to grow or remodel in response to the forces that it's placed under. So in summary, what this means is if you have more stress or strain, the bone is going to become larger. If our stress or strain is less, our bone will atrophy. So we need to think about that. If we are dealing with animals who have had fractures that have been repaired or TPLOs, if the animal has its leg immobilized, particularly for a long period of time, that bone is going to atrophy. And we don't want that bone to atrophy. But on the same standpoint, we do not want the fracture site to move. So it's really, post-operative rehabilitation is very much a balancing act. So we need to know about the healing time of all the tissues. And here's a reminder of the healing time of skeletal muscle. The inflammatory phase, just like everything else, is 72 hours. And then our repair phase is in about 3 days. We have the scaffold for the microfibers, but our normal collagen ratio is still not coming in till greater than 6 weeks, because muscle is repaired with an inferior type of collagen, type 3 collagen initially, and then the myofibrils come in and the fibroblasts, and they replace that with the proper type of collagen. If that doesn't happen, you end up with fibrous tissue. So we do not want our muscles to heal with a lot of fibrous tissue, or they're fibrosed. But we do need to remember that it's about 4 to 6 weeks minimum for this to be matured. And complete lacerations, 50% tension and 80% contractility at 12 weeks. So that's 3 months. And that's with a complete laceration. So partial, you'll get about 60% at 12 weeks. So we don't get a lot of return until much, much later with our muscles, but we get some. And how about the effects from disuse pre and post surgery? Well, and this is going to be, we need to consider if we have these patients who have been limping for quite a long period of time and not using their leg, then pre-surgery, they're going to lose a lot of lean muscle mass. What happens is we will have generally atrophy of the type 1 or slow twitch muscle fibers, generally the extensor muscle groups, and their associated tendons. Now, this is going to happen pre-surgery and, of course, post-surgery. But there is some thought, and I'm a person who does ascribe to this, to something called prehab. Prehab. So prehab is simply doing rehabilitation before you have surgery. There's a few reasons you might want to do that with your patients. One is, particularly if you're going to use pieces of equipment like the underwater treadmill, you'd like your dog to get used to it before it's had a surgical repair that it could possibly disrupt. The other thing is you can minimize the loss of lean tissue mass if you're able to put these dogs in your treadmill and do some prehab with them. You also get a chance to connect with the client and tell them and teach them how they can do their passive range of motion, because they're going to do that post-surgery, what kind of exercises they're going to need to do post-surgery, how the lifestyle management part looks post-surgery, so they can prepare, they can get ready for their dog having this surgery. They can maintain the muscle mass, they can get the elevated bowls, they can buy the yoga mats or whatever kind of mats they're going to use. They can buy the baby gates to block off the stairs so that when the dog comes home from the hospital, they're ready. They're ready to help it recover. But at any rate, whether it is pre or post surgery, we do have atrophy of the type 1 muscles, generally the extensors. And what happens is there's a biochemical conversion of the slow twitch muscle fibers, the type 1s, to fast twitch. And there's changes in the sarcoplasmic reticulum within the muscle, and so we have decreased strength. So not only do we have atrophy, we also have decreased strength. And then the other thing that happens is we have alteration of the muscle firing patterns. And that's what will happen in the affected leg versus the normal leg. So prehab can actually help with this. It's going to help decrease the atrophy, decrease the loss of lean muscle, slow down the conversion of the type 1 to type 2 fibers, and it will help also with the muscle firing patterns. So that's a good reason to consider doing some prehab. Now, how about effect on ligaments? Remember, if we immobilize a ligament, the ligaments are going to atrophy. And if the ligaments atrophy, there's a decrease in the maximum load to failure, and also there's a decrease in their structural integrity. So this is what happens if we put a bone that has a ligament, because remember, ligaments connect bone to bone, into a cast, or we immobilize it in some other way. But how about what happens with our cartilage? Because our bones have bone tissue, muscle tissue associated with them, tendons, ligaments, and cartilage. So what happens with our cartilage? Well, how is it affected by immobilization? We get degeneration changes that are going to occur because there's a reduction in the proteoglycan content and production. So our cartilage is going to stop producing or decrease the production of the proteoglycan. The other thing that happens with immobilization is it becomes thinner and there's loss of articular cartilage. And it actually will increase in water too. So there's a decrease in the cartilage matrix and cellular components, and there's also a decrease in the synovial fluid. So your cartilage becomes thinner, it becomes weaker, it becomes wetter, and it doesn't get any nutrition from the synovial fluid. So immobilization is not a good thing for cartilage. So in general, post-surgery, we want as little immobilization as we can to maintain the health of our tissues, but we need enough mobilization. We need to make sure we don't have too much mobilization because it will decrease the effect of our tissues, that it will cause atrophy and cause problems. Yet we don't want too much mobilization because that can disrupt our surgery and disrupt the healing. So we need to be very careful about what we do and how we time it. So what happens with proprioception with surgery? Well, surgery and immobilization compromises proprioception. And what happens with this is that because of the surgery, the animal's not putting weight on the leg, we have less input into the central nervous system. So there's less input into the central nervous system from the Golgi tendon organs, the mechanoreceptors, and the muscle spindle fibers. Those three. And we'll also get decreased input from the joints themselves and from the muscles and from the tendons because there's no weight bearing on there. There's no weight bearing. It decreases the input into the CNS. And also, we will get a reduction of the regulation of the reflexes and neuromuscular control because the nervous system is very smart. If it has part of it that it's not using, it just turns it off. Because why would you waste energy on something that you do not need? So if you are not using that particular function, it's going to become obsolete. The interesting thing about proprioception is that the deficit from proprioception can last up to 12 months post-surgery. And we see this in dogs and we also see it in people. So it's very, very important. The more time out we are from surgery, the more that we work on proprioception and that we continue to work on proprioception. So here's an interesting thought. Rehabilitation treatment of post-op joints can accelerate recovery time, and this is what we need to tell our surgeons, because I graduated from veterinary school a long time ago, 1984, and at that point, if you had an animal who had some kind of orthopedic surgery, they were supposed to be cage rested for like 8 to 12 weeks. And the surgeons many of them came up learning that, and I don't believe it's still taught that way today, but there are some people who are my age and probably learned that. But the interesting thing about rehabilitation is that it can accelerate the recovery time after surgery. So these are the things the surgeons need to know. And also, you can improve the results of any surgical procedure. So many times surgeons will say, these dogs don't need to have physical therapy, rehab therapy post-surgery because I do a really good job with my surgery and they'll heal just fine, and I'm worried that you will wreck my surgery. Well, first of all, it doesn't matter how good the surgery is, rehabilitation will make it better and the animal will recover faster and the client will be happier. So they need to think about that. The other thing is that rehabilitation practitioners in general are very good and safe practitioners and also very good at figuring out if there are complications with the surgery and figuring out what needs to be done and when they need to be referred back to the surgeon. The other thing is, if an animal is in rehabilitation, it's generally in seeing a veterinary rehabilitation professional a couple of times a week. So if you were the surgeon, wouldn't you like to know that somebody's checking your patient a few times a week and can head off any major complications? I would think so. But the big thing is to tell them that, they can be made to look really good because the results of any surgical procedure can be improved. So I'm all about goals because we need to know what we want to do. So what are our goals for our immediate post-op rehab? Well, the first thing we want to do is reduce the pain. And we're going to reduce pain, obviously, by drugs, because post-surgery, we're going to reduce pain by drugs. Non-steroidal anti-inflammatories generally are what are used, and you may indeed use some gabapentin along with that, and I'm a big fan of that. Opioids generally are not used chronically, but they can be used in the post-operative arena. A few other things that can reduce pain: laser. You might use a TENS machine, but the thing about a TENS machine is it only gives you about 15 minutes, 10 to 15 minutes post-TENS of pain relief, so that's not going to be very good. And of course, the other thing we can use is a CC loop, which we have right here. So we want to reduce pain, we want to promote healing. Some of our, absolutely, acupuncture we can do as well. We want to promote healing, maintain our muscle mass, and we want to promote muscular development and joint stability and maintain joint flexibility. The thing about joint stability is if your muscles are not strong, if you have decreased the neurological input to your muscles, then you end up with a decrease in the firing of the presynaptic pool of neurons for the muscle. The more that you decrease the presynaptic pool firing, the more you get muscle atrophy and the less stable your joint is. So joint stability is really a reflection of the number of neurons that are firing in your presynaptic pool. So it's kind of an interesting thing to think about. So other goals for post-operative rehab: retraining proprioceptive balance and coordination, and that, of course, we're generally doing with our exercise therapy, and we'd like to facilitate early return to function, prevent osteoarthritis, and rebuild our cardiovascular endurance. So how are we going to do this? Well, this is an exercise thing, right? Retrain proprioception, balance, and coordination. Also a PNF thing. We've talked about that. Early return to function. That's more you use it, you get to use it more. Prevent DJD. That can be exercises are very good for that, as well as there's supplements that you can use that are going to be helpful. And we're not going to talk today about the supplements in general, but there are supplements that you can use. And then cardiovascular endurance, the only way you do that is with exercise. So here's another little thought. We've kind of alluded to this, but rehab professionals are very good at addressing surgical complications, such as infection or surgical failure, tendinitis, tenosynovitis, and soft tissue adhesion. And you want to be very good at doing this because the surgeons are trusting you with their patients, and if you notice anything that's amiss, you really need to contact them. So our goals for post-operative rehabilitation are broken down into phase 1 and phase 2, pretty much. Phase 1 is immediately to 3 to 4 weeks. And since we're talking mostly about acute post-operative rehabilitation, this is the phase that we are going to focus on. It's going to be immediately following surgery. So we're looking at the initial inflammatory stage of the tissue healing through to the end mostly of the reparative stage, which is that lasts about 3 to 4 weeks. So here are our goals here. We're going to try to resolve the pain and inflammation and stimulate early tissue healing. Now, before I go ahead and tell you how we're going to do that, you've had enough of these lectures. I'd like you to think about that. So how are we going to resolve the pain and inflammation? Well, we have pharmaceuticals that we can do that with, right? And then we have non-pharmaceutical methods. Non-pharmaceutical methods can be things like herbals. It can be things like weight loss, maybe. And it can be things like modalities. So our rehabilitation therapy, our modalities, our exercise. So these are all the things that we're going to look at to resolve pain and inflammation. That's all the things we've already talked about. So when we talk about cryotherapy, we might even talk about heat. We're going to talk about laser, acupuncture, exercise therapy, underwater treadmill, all of these, ultrasound, a CC loop, all of these things that we do all the time that we do them. So stimulating early tissue healing. Well, that's an interesting thought. How do we do that? Well, many of the modalities that we are talking about, things like laser and acupuncture and our pulsed electromagnetic field therapy, those are going to help stimulate early tissue healing. So these are the things I would like you to think about as you go through these lessons. So this is an interesting case. I thought that I would bring this case up to you because this is a dog that had a TPLO done and was sent to me about 10 weeks or so after it had had its TPLO done, because it still wasn't using its leg very well. And I do a lot of rehabilitation of dogs post-TPLO, and when I first evaluated this dog, I did not think it was using its leg correctly and wanted to send it back to the surgeon, which I did, and she said, oh, I think it just has patellar desmitis, so I want you to do some rehab with this dog for at least a month, and then I'll evaluate it again later. And I'm like, okay, well, you're the surgeon. So here's what the dog looked like when I first evaluated it. Notice this dog's right stifle is collapsing. So to me, this tells me that the anti-gravity mechanism for that stifle is not working. The anti-gravity mechanism for the stifle is the patellar tendon. So I'm looking at this dog, and when I evaluated it, I'm watching it collapse with every step. I'm concerned about the patellar tendon. However, the surgeon was not. So I did indeed do some rehabilitation on the dog, but I want to show you some of the x-rays. Because remember, I said that rehab professionals are good and safe practitioners, and that we are very good at ferreting out surgical complications. So here is an interesting thing. The x-ray right here, this one was taken immediately post-op. And I'm not a surgeon, and I don't read an awful lot of x-rays, but it just doesn't look like most of the TPLOs that I have seen. However, this was the x-ray that was then taken when they took the dog back to the surgeon, and this patellar tendon is right here, and it's huge, and we do have the bone has healed here, but there is a little bit of an issue. We've got some arthritis developing here, but mostly I don't know what's going on there. So this was ultrasounded, and what had happened was that the patellar tendon actually had ruptured. So I was right that the anti-gravity mechanism for the leg was not working. But those are the things that you need to be able to look at and do. Just because someone sends you an animal post-op or sends you an animal at some point to do rehabilitation on, just remember that my first rule of rehabilitation, number one, assume nothing. Assume nothing. You have to make your own diagnosis regardless of what anybody else says. Assume nothing. And then continue from there. So here we go on with goals for the post-operative rehabilitation phase 1. We want to preserve the muscle mass. Obviously, we want to make sure that our joints and our articular cartilage are doing well and that they're getting, homeostasis. So we want the joint to get nutrition, right? And how do we get that? And we want to maintain by maintaining range of motion, right? Because that is how the joint gets nutrition, is from the synovial fluid. And if it's not moving, there's no synovial fluid pumping. It's not getting any nutrition. So we have to make sure things are moving. So I always say a few things. Motion is lotion. Motion is lotion. You move, your joints feel better. And what do we want to prevent? We want to prevent mechanically dysfunctional compensatory postures and movement strategies by the patient. So what that means is, if the patient cannot use its back leg and it is shifting all of its weight forward, it may have a roached back, it may abduct its elbows, it's going to put more weight forward, and those are the things that we want to prevent, because if we do not, we are going to end up with myofascial trigger points all throughout our muscles and everywhere else. So it's important to think about doing that. Now, phase 2 of post-operative rehabilitation is really covered in another lecture, and it targets challenging the healing tissues during remodeling phases, and you want to improve your strength and mobility and mobilize the scar tissue and enhance functional return. But that's not acute post-op. So when post-operative or orthopedic rehabilitation is covered, we'll talk more about the phase 2 healing. So let's go back to the acute phase post-op, immediate post-op, remembering that this is the inflammatory phase, right? That's immediate post-op up to 72 hours is the inflammatory phase. So what do we focus on in the inflammatory phase? Well, a lot of these patients are going to be in hospital, so we're going to focus on protecting the surgical incision, and that could be with a bandage, or it could be just putting a cone on the dog's head. We don't want that, And the other thing, as far as protecting it, is we want to have safe mobility. So I'm talking about using harnesses. How are we moving the dog around in the hospital? So all of those things are about protecting the surgical incision. Restricting physical activity, obviously, if the dog's in a hospital, it's going to be cage rested. We need these animals to be rested for a certain extent. Obviously, in the first 72 hours in the inflammatory phase, we need them to be restricted. Pain and inflammation control, in that case, we're doing things like laser, we're doing some drugs, we might be doing some acupuncture, we might be doing some icing, cold compression, those sorts of things. And maintaining joint mobility, well, we'd like to do passive range of motion of all the joints. So these are the things that we think about with our acute phase post-op. So here, restricting physical activity. I've already gone over these, but I figure that the more we go over them, the better. So cage or crate rest is pretty easy to do in the hospital. It's not so easy to do at home. So here's a few key points when you're prescribing cage rest to your clients. The owners need to be given a list of clear do's and don'ts. It's not just enough to say, "And Mrs. Jones, cage rest your dog." She doesn't know what that means. Maybe she thinks cage rest is just when they go to bed at night, the dog sleeps in a cage. And other than that, it's running around all over the place, going up and down the stairs, going down to the basement, going back up. Not a good plan. So we need to give a very, very specific list of what the dog is able to do and what it's not able to do at home. Cage rest, crate rest, Great Dane, it's room rest. So something along those lines. Dogs should be restricted to a leash walking only regime, and usually we have to carefully adjust their interior and yard activities, because we don't want running, we don't want jumping, we don't want slipping. So if that means putting down carpet runners, if that means keeping the dog with the baby gate out of the place where the hardwood floor is, something like that. But you need to sit down and have a very good discussion with the owner regarding that. So marked exercise restrictions. So this is crate rest. So this is a little dachshund that had back surgery, and it is being rested in a playpen because the client didn't have a cage and wanted to make sure that the dog was rested and asked me if this was okay. And this is fine for this dog. And it's necessary and you can achieve it, but the owners find it very challenging, especially if this little dog is there whining and complaining and carrying on, that the client isn't there to take it wherever it wants to go. So you need to have that discussion with your clients. Attention to detail is key to recovery during exercise restriction. So you have to tailor the advice to the patient, to the patient, the owner, and the home surroundings. So it's a good idea if this dog is going home from surgery or has come from the surgeon into your rehab facility, you need to have a good discussion with them about lifestyle management and what they can expect. And the thing that I will usually tell them is, you realize this is not forever, because to the owner, it seems like it's forever, but it's not forever. So how do we protect the surgical incision? Well, this dog has on its little shirt that's going to protect that, and it's of course still in its crate because we don't want any seromas. But this little dog is on a very slippery floor. So flooring is, of course, one consideration when you're protecting the incision. And this dog, I don't think, has had any surgery. But if it did, I would not be wanting it walking on this very slippery floor. So here's what happens from a healing standpoint. Excess activity overloads the tissues that we want to heal and might contribute to complications like seromas or tendon inflammation, which is patellar desmitis. That's one of the things that we see post-TPLO in very active dogs. Implant failure, one of those sorts of things. So we do really need to make sure we're protecting that surgical incision as much as we can. Now, lifestyle management. So we've kind of been talking about this already, but the clear guidelines as to what activities are and are not allowed. I can't stress this enough. I have a handout for animals that are going into cage rest and saying exactly what they need to do. And if I were doing surgery, I would have one of those. I do have a rehabilitation and what to expect the first 3 to 5 days post-surgery. And I will tell them that safety is the key because, number one, the clients have spent a lot of money on these procedures, and the surgeon has spent a lot of time. And for the sake of the dog, nobody needs a second opening night. So if they have had surgery, we need to make sure that they're going to be safe. So here are some assistive devices that you can use post-surgery. This is a Help 'em Up harness, and I think Help 'em Up harnesses are a very, very nice harness to use post-surgery, for particularly if you have a large dog and it's had a cruciate repair done. It's nice to be able to let Mrs. Jones bring the dog in and out safely. And you can use this. It has a front end handle. It has a back end handle. You can use it to go up and down the stairs if the stair, not a lot of stairs, but the dog has to get out to the bathroom. So up and down maybe the few stairs that it has to go in and out. Could obviously build a ramp in that case if you needed to. This is another one. This is called a walkabout harness, and a lot of times people will use that. It's more like a sling kind of thing. It's okay, and I think if you have a dog that has had back surgery, you may want to wait before you're using this, which goes over the back. This part is actually open and just really goes under the belly. So it totally depends on what kind of surgery the dog has had and what's going on with the environment that the dog is in, and how big the owner is that has to take the dog in and out. How big is the dog? So your assistive device is really going to depend on that. Now, pain and inflammation control. We are best to use both pharmaceuticals and non-pharmaceuticals. So here's a couple of drugs on here that we will use in the post-operative phase. So gabapentin, like I don't have a picture of a non-steroidal anti-inflammatory, but the non-steroidal anti-inflammatory, those ones are going to always be the number one choice post-surgical for most surgeons. There are many of them: meloxicam, carprofen, the Previcoxes. The one that I would make sure that I am not using, though, is Galliprant, because Galliprant is really for arthritis, and it's not going to be helpful with dogs who are having post-surgical pain. You're better to use an NSAID and gabapentin, because gabapentin is for nerve pain, and anytime that you're cutting a bone, breaking a bone, anything like that, you're going to have nerve pain. And this is a mantidine, so if you can't use an NSAID because the dog is sensitive to it, you want to use something else along with your gabapentin. Gabapentin and a mantidine are a lovely combination. Your gabapentin dose is anywhere from 5 to 40 milligrams per kilogram, BID to TID. Older dogs, we start lower. Kidney issues, we start lower. Your amantadine is once daily, and it's usually 3 to 5 mg per kg. Once daily. SID is how I pronounce it. These are the dog doses. Cat doses are different. But what are we going to use for post-op pain and inflammatory control? Well, NSAIDs, gabapentin, amantadine. If it's just immediate post-op, you may use an opioid. But remember, we don't use opioids more than about 72 hours post. But you might use buprenorphine. You may use Torbagesic. You may use hydrocodone. But those are generally given in the hospital and not going home with the clients. So we have some drugs on board. That's a good thing. What else can we do? Well, immediately post-op, icing is good. Now, this is our cold compression. We use that in dogs who have had a stifle surgery, and it's icing and compressing works really well. You can just use ice packs, or you can use bags of frozen peas. You can make your own ice packs up, but you need to be doing some sort of icing. In the inflammatory stage, which is the first 72 hours, you need to ice at least twice a day, maybe 4 times a day. It's possible you might have to do it that much, because it's going to decrease pain and it's going to decrease inflammation. Few other things that are going to decrease pain and inflammation: laser therapy, that's what we're looking at right here and here. Those things are very good at decreasing pain and inflammation, and we use laser a lot post-op. What else do we use? You could use a TENS machine, but again, that's only going to give you about 10 to 15 minutes of pain control, so really not reasonable. You can also use pulsed electromagnetic field therapy, which is going to be your CC loop. That's going to be a very, very good thing for pain and inflammation. If you know how to do it, if you've been trained, you can also do things like edema massage. That's going to help the inflammation. Just basically rubbing the fluid up towards the heart, that's going to be helpful. So those are things that you can do, your client can also do. So here we have a few other things that we've put on here. So this is our NMES. The NMES isn't really going to do an awful lot for pain, but I really put this on here to show you that it would be similar to the TENS, But this is joint mobilizations, and you can do very good joint mobs as well. And this is an NMES. Yeah, it might help a little bit with pain, but it's mostly for muscle contraction. So you need to maintain joint mobility in all of the joints. So we need to show the clients how to do passive range of motion. And remember, we're doing all the joints. You're going to start with your toes, and then you're going to do your tarsus and your stifle and your hips. But obviously you have to protect the surgical area. You're not going to do a huge amount of passive range of motion and do huge excursions like this if you have a dog with stifle surgery. You're going to move the toes and the hock and the hip as much as you can, and you're going to move the stifle only in the area of comfort. The idea is not to make the dog painful. We don't want a painful patient. So joint mobilizations are things that our physical therapists are doing, and I think most veterinarians who are doing rehabilitation therapy don't have any idea what joint mobilizations are or how they work. So we're going to spend a little bit of time talking about joint mobilization. We'll talk about that just a little bit later. We're going to encourage some active range of motion with our patients, and we're going to do that post-operatively, but not right in the inflammatory stage unless the dog is really, really doing quite well. But there are early weight-bearing activities that you can do. You can do cookie stretches. You can obviously do high fives and very easy balancing. Stretching is probably a good passive range of motion activity, and it's going to enhance early muscle strengthening. So these are dogs that are doing cookie stretches. So what the cookie stretch is actually doing is it's causing the dog to do some weight shifting. This one, the dog is having to weight shift to the front. This one, it's weight shifting to the right side. And this is just a little dog that's balancing on a pad. And this is an easy, good one to do, side-to-side range of motion that you can do post-operatively because it's easy to do. It's kind of like doing a cookie stretch, but you're getting the whole dog to go to the side. And sometimes if you're having an issue trying to get them up, that's going to be a helpful way as well. Sit to stands are things that you can use very early post-op as well, and it's pretty easy to get your patient to do that. It's just an activity of normal living, so that's what we really want to do. We want to do some activities of normal living. And a play bow, if your dog will do this, is also a very good exercise. And again, in the acute post-op stage, you're not going to do anything that is going to cause your dog to be painful or that's unsafe. So proprioception is something we have to work on in the acute post-op phase. And grade 1 joint mobilizations help to stimulate the Pacinian corpuscles and the Ruffini endings in the joint capsule and awaken the mind-body awareness. So that's something that's very important. So joint mobilizations, massage, and then weight shifting activities. We just talked about weight shifting activities with our sit to stand, with our play bow, with our cookie stretches. So those are all very good proprioceptive things. Massage, we've talked about that. And joint mobilizations, I promised you we would talk about. So we're going to talk about it right now. So what are joint mobilizations? There's a few things we need to know about as far as terminology before we talk about joint mobilizations. There are in and around bones, there are something called physiological movements, and there are accessory movements. Physiological movements are movements that the patient can do voluntarily, and that's something called osteokinematic, or motions of the bones. And accessory movements are things that a therapist is going to do. So it's not voluntary motions, but it is components of that. And when we talk about accessory movements, we're talking about arthrokinematics, which is motions of the bone surfaces within the joint. So we have osteokinematics and arthrokinematics. So mobilization is really passive joint motion for increasing range of motion or decreasing pain. That's really what it is. That's why we do it. We apply it to joints and soft tissues at varying speeds, and that's how we get the grades. And the force is light enough that the patients can stop the movement. So it's never going to be painful. It's never going to be high force. That's mobilization. Manipulation, that's your chiropractic adjustment. It's going to be a passive joint movement for increasing joint mobility, and it tends to have a very sudden forceful thrust, and the patient can't control that. So that's the difference between a mobilization and a manipulation. So here's your joint shapes and arthrokinematics. How does this work? So there's 5 types of joint arthrokinematics: rolls, spins, slides, or glides they're also called, compressions, and distraction. Compression and distraction is pretty easy. The other ones are maybe a little more difficult for us to understand. But joint mobilization does combine rolling, spinning, and sliding or gliding. So types of motion, here's a rolling. I think that's pretty easy to figure out what's happening there. Rolling is always in the same direction as the bone motion, whether the moving bone is going to be the convex or the concave. Okay, rolling is always in the same direction as the bone motion. Okay. Spinning is around an axis, so it's pretty easy to see what spinning is, always around an axis. So now we've done a roll, we've done a spin, and then the slide or a glide. We have a specific point on one surface coming into contact with a series of points on another surface. So if we have a passive mobilization technique that's applied to produce a slide in the joint, it's referred to as a glide. So the more congruent the surfaces are, the more sliding there is. The more incongruent there are, there's more rolling, right? So that's pretty much what those 3 things are. So the Maitland grading system, because we have grades of mobilization, the Maitland grading system is pretty much 1 to 5. 5 is going to be a chiropractic adjustment. But when we look at, these are the ones we usually do for post-operatives, grade 1s and maybe grade 2s, because these are managing pain and spasm. And this is a small amplitude that's at the beginning of the range of motion only. So if you're doing a range of motion, you can do a small rhythmic oscillation. So you're moving back and forth and back and forth and back and forth at the beginning of the range of motion, like this. And a grade 2 is a large amplitude that goes in the mid-range of motion. So we'll assume this is your whole range of motion. So 2, you're going back and forth, but you're in about the mid-range. You're not going the entire range. And it's for pain and spasm. So grade 1s and 2s are used before 3s and 4s. So these are really the ones for pain and spasm, which is why they're for post-operative. 3, 4, and 5 are really to try to increase your joint movement, increase the range of motion of the joint. And so here it tells you with that. You use to gain motion within the joint, stretching the capsule. That's going to be your 3, 4, and 5 is going to be your chiropractic adjustment. But since we're really talking about post-operative rehabilitation, we're really talking about just grade 1s and grade 2s, because we're not stretching the joint capsule and the connective tissue. But you see how the 3 is a large amplitude and then the 4 is a small amplitude at the very end range of motion. So we're going to use grade 1 joint mobilizations for the acute post-op period. So it's going to be at the beginning of the range, and it's going to be small amplitudes. Okay? We're also going to use massage, which we have talked about before. And we're going to use weight shifting. So those are the things that we really use with our post-operatives. So our subacute phase, this is where we're strengthening. We have soft tissue stretching and range of motion, and we're working on our proprioception. So for strengthening, we're doing hydrotherapy, pause up, low hills, slow pace, cavaletti. This is really getting out past the true acute phase. Here's our soft tissue stretching. That you can easily do at just about any time in the rehabilitation phase. And cavaletti, we certainly have seen how this works. If I was doing this acutely post-op, I would certainly do these a little bit lower for this dog, but don't we're working on flexion and extension, and we're working on proprioception. Always good to work on proprioception. This is just a little table for you to show what elbow dysplasia post-arthroscopy would look like. Again, just so you can see what we use. Pain meds, cryotherapy, heat, massage, passive range of motion, and how does this work all the way out to 8 to 12 weeks. So, you can see what we're doing mostly with these elbows. And the passive range of motion is something that we really continue to do. Here's our laser therapy and our walks, because laser we go from doing daily to twice weekly, and then when we get out here to 8 weeks, it's really only as we need it. This is how we increase our walks, but you should have this table within your notes so that you can see how this works. But you notice that we go from a 5-minute leash walk a couple times a day right up to a 15 to 20-minute leash walk 2 to 3 times daily with a harness. So we are using harnesses, and we're being very, very careful. And this is also showing you things like NMES for the muscles, balancing, when do we start that, cavalettis, shaking, hills. You see, hills we don't start till 4 weeks. And then our underwater treadmill with our post-surgicals, we can usually start those at 2 to 4 weeks. Swimming, 4 to 8 weeks it says. I prefer personally not to start any swimming until they're at least 6 weeks out. So this is the conclusion of our acute post-op rehabilitation. If you have any further questions, please post it to our message boards, or you're certainly welcome to send us an email.